I think the first thing that's going to happen in the next few years is personalised breast screening. I think at the moment we only screen people based on age and on sex, but we have lots of other interesting reproducible risk factors such as breast density, breast texture, parenchymal enhancement on MR, and also SNPs, sort of single nuclear polymorphisms that we all carry that affect our risk. What we haven't yet done is try and put all those together to come up with a risk score, but I think in 5 years' time, hopefully we'll be able to tell some women that they don't need screening at all and some other women that they need more intensive screening and personalise when you start, when you finish, and how often. And I think that will improve breast screening. I think some of the challenges is that we need to get people from very different areas, people from genetics to talk to people who are into MRI, to talk to people who are into family history, because we've got very disparate sources which are often looked at by different people. And we need somehow to stick all that together into an algorithm that's usable and easy and friendly. And it's also about patient acceptance, I think. Some of the time people think they have a right to have a mammogram, but they don't have a right to have a CT scan. And I think breast screening is such a political issue that if you're going to say we're going to rob Peter to pay Paul, then Peter's not always going to be happy. But in the long run, we have to spend the precise budget we have in the best way to save as many lives as we can and do as little harm as we can. And breast screening is always a balance between benefits and harms. The other topic that really came up is the use of breast MRI. In one sense, it's a fantastic test because it's very sensitive to detecting invasive breast cancer. But on the other hand, if this might sound peculiar, but it actually detects too much breast cancer, because if you use it, it's easy to increase your mastectomy rates because you're finding other tiny bits of cancer within the breast that if you didn't do an MRI, you wouldn't find out about. And in actual fact, very few of these actually cause local recurrence if you give people whole breast radiotherapy and systemic therapy. So it's almost finding tumours that are too small for us to know what to do with, because the basic paradigm is if there's cancer there, you cut it out, where MRI finding these tiny areas of cancer that we didn't know about before, if you chop them all out, you end up over-treating patients. So it's understanding the natural history of these small foci of cancer that we didn't know about before, and knowing how to treat them, but not to over-treat them or under-treat them. And I think that's a very tricky issue that will take a few years to sort out, I think.